Ready to talk about the pharynx, what we would commonly call our throat, which is a structure that is divided into 3 divisions. And I'll let you guys fill in the blanks on those. And then we'll go through and learn about it. All right, what we commonly call our throat is the pharynx, a skeletal muscular funnel extending from the base of the skull to the level of the cricoid cartilage or larynx. And we'll learn about the cricoid cartilage and the larynx here on the next slide. Okay, location is just posterior to the nasal and the oral cavity, so it's just behind the nose and behind the mouth. Oral cavity is fancy word for your mouth. It's superior to the larynx, and then just anterior to your cervical vertebrae, which are those small vertebrae in our neck. So that's its location. It's a structure that we will talk about again in our next lecture because it's a common pathway for our respiratory and digestive tracts. It carries air into the larynx when we breathe, whether that's when we breathe through our nose or through our mouth. And then when we swallow food and liquids, it's going to pass that through the pharynx and into the esophagus, which is a tube that carries the food or the beverage, whatever that liquid is, to our stomach. And our pharynx also provides a resonating chamber for speech sounds and houses our tonsils, which is why we've actually seen this picture before. If you don't remember, that was a picture that I included in our, what was it, the lymphatic lecture, where we talked about the 3 different tonsils that you can see, the pharyngeal, the palatine, and the lingual, although this image is now significantly more complicated with a lot more lines than what you saw where I basically deleted everything else out of there and just identified those. So we've seen that picture before, but now obviously there's quite a bit more to look at. The 3 divisions include the naso, the oro, and the laryngopharynx, and those are going from superior to inferior. So the nasopharynx is the superior most, in the middle is the oropharynx, and then the inferior most is the laryngopharynx. This little guy down here has them kind of color coded, which is kind of handy, but it's not really something I'm going to refer to. Just right there. Let's talk first about the nasopharynx, which lies posterior to the nose, which is where its name nasopharynx comes from. It extends to the inferior portion of the soft palate, which forms the posterior part of the roof of the mouth. Okay. There are 5 openings associated with the nasopharynx, 2 from the internal nares, which we talked about those the other day. Those are the openings from the nasal cavity into the throat. Okay. And we've got one of those labeled here, since this is showing you only half of the head. Since it's a parasagittal plane, half the head's been removed. And that's why you see it's labeled here as an internal nares with the letter I instead of E, because it's singular. Okay, we see the same thing for the external nares that's labeled here. If there was 2, it would be nares. Okay, and there are 2, but there's only half of the head in the picture. Okay, so those are 2 of the openings, and you have 2 openings that lead to the auditory or eustachian pharyngotympanic tubes, which, remember, those are the tubes that connect to our middle ear, and thus is why, for example, if you plug your nose and blow, you can feel your ears pop because you're going to build up pressure in that tube and then the middle ear as a result. And then there's one opening, and that leads to the oropharynx. Okay, within the nasopharynx is the singular pharyngeal or adenoid tonsil that we've seen before. On the inside, lining it, is a pseudostratified ciliated columnar epithelium, which we've talked about way back at the beginning of the semester. Pseudostratified means that it looks like it's multiple layered, but it's actually one. Ciliated means it has cilia, and the cells are columnar in shape. The cilia here helps to move the mucus down towards the inferior parts of the pharynx. Most notably would be first the oropharynx, which gets its name because it's posterior to the mouth. Anytime you see oro or oral, it's going to refer to the mouth. Okay, extends from the soft palate, which is what we just said is the back of our roof of our mouth, to the level of the upper border of what's called the epiglottis, which is this structure here. We'll talk a little bit more on the next page. Okay, it contains only one opening for the mouth, which is known as the fauces. And in this picture, it's kind of misleading. This is what the food and the drink, when we swallow, travels through. It looks very small, but that's just kind of because the tongue is pressed upwards and almost touching the roof of the mouth. So it makes it look a lot smaller than it really probably is. Okay. The nasopharynx, unless you are a weirdo that ingests your food by snorting it or your liquids by snorting it, okay, the nasopharynx strictly functions in breathing, respiration, whereas the oropharynx, we swallow through our mouth. We can also breathe through our mouth. So the oropharynx functions in both respiration and digestion. Okay. It is lined with a non-keratinized stratified squamous epithelium, so it's a little bit different than what we just saw for the nasopharynx. Non-keratinized means that it doesn't have keratin. Stratified squamous tells you that there's multiple layers and the cells are flat or plate-like. And this helps protect against the abrasive nature of food. Okay. And located within the oropharynx or associated with it are the pair of palatine and lingual tonsils. Okay. So there's 4 tonsils associated with the oropharynx. But the final region is the laryngopharynx, which also goes by the hypopharynx. It extends from the hyoid bone to the esophagus posteriorly into the larynx anteriorly. And it's going to pass the food to the esophagus and air into the larynx. It is lined by non-keratinized stratified squamous epithelium, just like our oropharynx is. Now, this is an image that you can pretty much bank on seeing on the exam next week, and that's because this is going to contain structures relevant to both of our 2 lectures. Okay, so it's a very important image, and some of the things we talked about last time are visible here, especially the stuff associated with the nose or like the couple of sinuses that you can see, and then some of these structures will be discussed more on like the next lecture or even the very next slide. So let's highlight the following. I'll just go down the line here on the left side. I want you to highlight the sphenoidal sinus, internal nares, pharyngeal tonsil, nasopharynx, which is just the region, opening of the auditory tube, the uvula, that's the thing that looks like a little punching bag in the back of our mouth, the palatine tonsil, the fauces, which again, that's the opening that we swallow through. That whole region is the oropharynx, the epiglottis, the laryngopharynx, and then the esophagus and trachea. So I guess it would have been easier to tell you what not to highlight on that side, but that's okay. On top, I want you to highlight the 3 nasal meatises. Okay, the superior, the middle, and the inferior. Keep in mind, those are different than the nasal conchae, which I actually want you to highlight. Okay, the conchae are the little bumps. Okay, these are the projections. Remember, those are the folds of tissue. If we go back to this picture, which is from a cadaver, you can see them. Remember, the little meatises are the little channels. That's where the air flows. Okay. So the meatises are that little crevices, whereas the conchae, which also are described as turbinates, those are the bumps. Okay. On the top right, I want you to highlight the frontal sinus. Olfactory epithelium we've talked about before. Go ahead and highlight it. Remember, that's the upper part of our nasal cavity where the receptors for the sense of smell are located. If you didn't already highlight, make sure you highlight the 3 nasal conchae. Nasal vestibule, that's kind of the part of our nose that we can flare out. That's where like you're going to find the boogers in the hair. External nares, remember that's just a fancy term for our nostril, the opening into your nose, whereas the internal nares is the opening from the nose into the throat. Okay. Highlight the oral cavity, the soft palate, the lingual tonsil, And then just the larynx. We're going to talk about a lot of these other parts, like the folds and the cartilages. We've already talked about the gland. That's not really relevant to what we're talking about here, but you can see it nonetheless. Just the larynx is what you need to highlight. And we're going to talk about that here in just a second. Here is essentially the same view of it, just from a cadaver, where you can see those structures very nicely, along with parts of the brain that we've talked about before, which is kind of cool. There's a very nice view of the frontal sinus. There's the sphenoidal sinus. You can see the nasal conchae. You can see this is the opening from the nasal cavity. So this would be the internal nares. And now right in here, this is all pharynx. Obviously, this is inside the mouth. There's the tongue. You can see like this is the hard palate, which is going to make this a soft palate. Here's the epiglottis, which is pretty cool to see. And we'll talk about that epiglottis along with some of those structures that you can see here in our next couple slides. Let's talk about the larynx, which includes that epiglottis I just pointed out. Like the pharynx, we have a kind of more common term for the larynx. What we would commonly call our larynx is our voice box. Our sounds are created. Is that it? It's okay. Once again, larynx, we commonly call our voice box, lies between the root of the tongue and the upper end of the trachea, just below and in front of the oropharynx. It consists largely of cartilages attached to one another and to surrounding structures by muscles or even more cartilage. It is part of the airway to the lungs and is lined with a ciliated mucous membrane that helps remove dust particles. The reason we call it the voice box is the organ of voice production, by way of vibration of the vocal folds, producing the sound. The vocal folds were actually, if I go back here, labeled on this picture. It's kind of too hard to tell them apart, which is why I didn't tell you to highlight them, and not to be confused with the vestibular folds. But those produce the vibrations that produce the sound, but the size and the shape of our nose, the mouth, the pharynx, and the bony air sinuses help determine the characteristics of our voice. It really can be demonstrated by trying to speak without moving your tongue. Okay? You're not going to be able to form words without your tongue, which you watch movies or you think about once upon a time when it was common for people to be punished by cutting their tongue out. Then at that point they really can't verbally communicate very well because it just sounds like they're making random noises. They can't use their tongue anymore. Obviously they don't have it, so they can't make words. All right, as a whole, there are 9 cartilages that form the framework of the larynx. We'll start with the epiglottis, a flexible flap of tissue that guards the superior opening of the larynx. And this is the structure that prevents us from choking. Okay, think of it like a trap door, which has the ability to go up and down. Okay, and when it is in the up position, which is what it is right here, this is going to allow air to flow directly into the larynx and then down into the trachea. Okay. That's not what we want to have happen when we swallow, whether that's liquid or food. So what the larynx or the epiglottis must do is it must pivot back down, and it comes across and it will cover this space right here. And so the food and the liquid, whatever it's going to be, will slide to the backside into the esophagus. And we've all accidentally got stuff into our wrong pipe before, and that's where the epiglottis did not do its job correctly. There's 2 parts to the epiglottis, the stem and the leaf. The stem is the tapered inferior portion attached to the anterior rim of the thyroid cartilage. The leaf is the broad superior portion, is unattached, and that's what moves up and down like the trap door. Okay, we've got an anterior view and a posterior view to show it very nicely. Here in the posterior view, we get a good view of both the leaf and the stem. Here is a sagittal section where the larynx has been cut in half from front to back. You can see the epiglottis. I don't really like this image, kind of tricky, but there are a couple things that you can see here, and that's why I included it. These are the two images that I'll kind of refer to the most. Okay. Your epiglottis covers the glottis, which is the upper region of the larynx when we swallow to prevent the entrance of food or drink into the trachea. Your glottis is going to consist, I should say consists, not consists, consists of a pair of folds of mucous membrane, which include the vocal folds or the true vocal cords and the space between them, which is called the rim glottitis. And we can actually see the true vocal folds or vocal cords right here shown very nicely. But the rim glottitis is not labeled. The thyroid cartilage is what we commonly call our Adam's apple, that very broad projecting anterior projecting structure on the front side, but also it forms a good portion of the lateral and posterior walls of your larynx. Okay. This little indentation, I'm sure it has a name, but it's not labeled, so I don't even know what it is. You can actually kind of feel for that. If you want to, you can try to find it, but that's all part of your thyroid cartilage. Okay. Function of it is to protect the front of the larynx, and is more forwardly projected in men because it's larger, and that is due to the influence of the male sex hormones, especially testosterone. Okay. A ligament known as the thyrohyoid membrane connects the thyroid cartilage to the hyoid bone, which is where that name thyrohyoid membrane comes from. Just inferior to that is the thyroid gland, which is I guess the reason, I don't know which one was named first. I guess that's kind of like the chicken or the egg, but those are named, together for a reason. Now, that thyroid gland is really doing a pretty good job of covering up the next structure that I want to talk about, which is the cricoid cartilage. We can kind of see a little bit of the blue shading here in the picture, but we get a much better view of the cricoid cartilage here on the backside where the thyroid's not covering it up. The cricoid cartilage is a ring of hyaline cartilage forming the inferior wall of the larynx. It also happens to be the landmark for making an emergency airway in the little procedure called a tracheotomy. It's connected to the first ring of tracheal cartilage by the cricotracheal ligament, and it is connected to the thyroid cartilage by the cricothyroid ligament. And you can see the cricothyroid ligament very nicely. The cricotracheal ligament, you can see it over here on the backside view as well. Together, the thyroid and the cricoid cartilage essentially constitute the box of our voice box. And the last 6 cartilages are all in pairs. So we got a pair of arytenoids, a pair of corniculates, and a pair of cuneiforms. The arytenoids are posterior to the thyroid cartilage and serve as a point of attachment for the vocal folds. They contain elastic ligaments that vibrate when skeletal muscles move them into the path of outgoing air, which is what produces the sounds. Okay. The arytenoids, if you look very hard, I'm going to zoom in, are these little doodads right there. Now at the very tip of them, they look like a little kind of fingertip that's kind of bent a little bit, are the corniculate cartilages. Okay, so they are horn-shaped pieces of elastic cartilage attached to the apex of each arytenoid cartilage. And then the cuneiforms we aren't going to be able to find in these 2 images, and that's because they're only visible here in the sagittal section, but they are club-shaped elastic cartilages anterior to the corniculates, and they support the vocal folds and lateral aspects of the epiglottis. Okay. The mucous membrane of the larynx forms 2 pairs of folds, a superior pair of what we call the vestibular folds or false vocal cords, and then an inferior pair, which is what we call the vocal folds or the true vocal cords. Okay. Down at the bottom is a kind of cool pair of pictures where we've got the larynx from a cadaver looking at the anterior side of it and the posterior side. They don't have everything labeled, but you can see like the arytenoids, the corniculate, or the corniculates. I always try to say it a different way, but yeah, the corniculates are these little white doodads right there. Not going to worry about those 2 images. These 2 images are the ones you need to know. So here's what you need to highlight. The top here, the epiglottis, where we can kind of see it projecting up above the hyoid. The thyrohyoid membrane, I want you to highlight because it's nice and visible. The epiglottis again, but make sure you also know the two parts, the leaf and stem. Highlight the corniculate cartilage, the thyroid cartilage, retinoid cartilage, the cricothyroid ligaments, and then the cricoid cartilage. I won't worry about any of the other stuff that's there. All right, moving on down from the larynx, we will now talk about the trachea, which also has a nickname, what we commonly would call our windpipe. And then since they are very closely associated with it, we'll go ahead and talk about the structures making up your bronchial tree on this page as well. All right, once again, trachea or windpipe, it's a flexible muscular tubular structure just beneath the larynx. It's about 12 centimeters or 5 inches in length, about 2.5 centimeters, which is right at an inch in diameter. It extends from the larynx to the superior border of our fifth thoracic vertebrae. That's where it forks to divide and form a right and left primary bronchi, which also go by the term main bronchi. Now you're going to see this word bronchi a lot, which is the plural form of the word bronchus. You'll see bronchus sometimes, like right here, I guess there's a good spot to show it. Okay, bronchus is singular, but since we're talking about both of them, it would be plural. Okay, so looking at our couple images, here's the trachea. It's the singular tube, and then you can see where it forks. The two bronchi that are formed there are the right and the left primary or main bronchus, as it's labeled here, whereas up here at it, primary, same thing. Okay. Location of the trachea is anterior to the esophagus. It is made up of stacked rings of cartilage with fibrous spaces. The wall of the trachea is made up of 4 layers, and that includes a mucosa, a submucosa, then a layer of hyaline cartilage, and then the adventitia. It's going in order from deepest to superficial. So the mucosa is on the inside, the adventitia is on the outside. Okay. Mucosa, once again, is the inner layer. It's composed of an epithelial layer of pseudostratified ciliated columnar epithelium, and then an underlying layer of lamina propria, which is connective tissue where you find elastic and reticular fibers. Within the mucosa are mucus-producing goblet cells, which makes a lot of sense. There's also ciliated columnar cells. Okay. And what the mucus does is it helps trap like dust particles that we breathe in. Think of it like a glue trap that you can put like up in your house if you want to catch bugs and mice. Okay. The ciliated columnar cells use the cilia to move the mucus and the particles attached to that mucus upwards towards the pharynx. And then at that point, what's going to end up happening is we'll either kind of like cough it up and spit that mucus and the gunk out, or what probably happens a lot more is actually that that contaminated mucus moves down into our esophagus and then down in the stomach and is digested. Sounds really gross, but it's really actually, you know, a normal thing. Surrounding the mucosa is the submucosa, a layer of areolar connective tissue. Not a whole lot to discuss there. The third layer is a very important layer. It is made up of hyaline cartilage. It is made up of 16 to 20 C-shaped rings that wrap around the submucosa. If we look at this image here, it gives you a good view of that cartilage, and the shape that it has is very visible with this kind of white shading. We can see the letter C very nicely, although it's not, you know, like it would be drawn normally. It's kind of upside down. But That's a C shape, which is very important, but the open part of the C is not completely void. It has got something in there, and that's a muscle, which I'll talk about now. Okay. The open part of the C-shaped rings faces posteriorly toward the esophagus, is spanned by what we call a fibromuscular membrane, where you find a special type of smooth muscle that has a special name, the trachealis muscle. This muscle allows the trachea to change its diameter very slightly, but it does change it nonetheless when we inhale. Okay. Basically, what's going to happen is that muscle will relax, which allows this ring to expand a little bit more, and then basically the trachea opens up more significantly. Whereas when this muscle contracts, it kind of pinches the trachea more closed. But keep in mind, the rigidity of the rings prevents the collapse of the trachea when we inspire. Okay. In other words, the trachea should never completely collapse, which is very different than what we'll see in our next lecture. The esophagus absolutely can collapse. It doesn't have that cartilage in it at all. The esophagus is made up of muscle, not at all any cartilage. Finally, then you got the adventitia, which is the outermost layer made up of areolar connective tissue, which just joins the trachea to surrounding structures. All right, connected to the trachea and then extending into the lungs is a branching system of air tubes called the bronchial tree. It begins at the inferior portion of the trachea, helps divide the chest into right and left structures, and carries gases into and right left lungs. Okay. The branches include, and we'll start with the biggest and then work out to the smallest, are the primaries or the main bronchi, which are the ones that arise from the trachea, and we've already mentioned them. The right main or right primary bronchus goes into the right lung, left main or left primary goes in the left lung. Pretty straightforward there. At the point where the trachea divides into the main bronchi, an internal ridge called the carina is formed by a posterior and somewhat inferior projection of the last tracheal cartilage. Okay, so in other words, the carina is where those two split from one another. Okay, and you can see that's labeled in this image. It would also be not labeled here, but it could be right in that spot right there. Okay. From there, the secondary or lobar bronchi are formed. They are therefore the branches of the main bronchi. There's one lobar bronchi for each lobe of the right and left lung, which is where their name lobar comes from. Lobar for lobe. Your right lung includes a right superior lobar, a middle lobar, and an inferior lobar bronchi, which means your right lung has how many lobes? 1, 2, 3. Your left lung has a left superior and an inferior lobar bronchi, which means your left lung only has 2 lobes. Okay, and those lobes are actually color coded here in the picture. The pink shows you the superior lobe, purple for the middle lobe, and then the inferior lobe is in blue, whereas we only see pink and blue here on the left side. And that's because your left lung is actually smaller than your right lung. And that's because of this structure. Actually, it's not really a structure, but it's an indentation called the cardiac notch. Guess what fits right there in that nice spot? Your heart. Remember, the heart sits to the left of the midline for the most of part anyway. About 2/3 of it does. So it actually impedes on the left lung, and therefore the left lung is a little bit smaller. From the secondary or lobar bronchi come the tertiary / segmental bronchi. Okay. There's one segmental bronchi for each of the bronchopulmonary segments of the right and left lung and are named as such. Okay, and we're going to get into the bronchopulmonary segments, but those are just the smaller subdivisions of the different lobes of our lungs. From there, the branches that are formed are called bronchioles. And they are surrounded by smooth muscle and are 1 millimeter or less in diameter. So we're getting down to pretty small, but not super small yet. The final branches of the bronchial tree are called terminal bronchioles, which makes sense. We call them terminal because terminal means end. And these are the tips of the tree. They are less than 0.5 millimeter in diameter, but they are truly not the last airways. Okay, and that's because they subdivide into microscopic branches called respiratory bronchioles. And budding from those are the air-filled cells called alveoli, which will be discussed more on the next slide. And we'll get into that, like I said, here in just a second, but we did mention them earlier in the lecture. Now, as the branching becomes more extensive in the bronchial tree, several structural changes occur. The mucous membranes in the bronchial tree change from pseudostratified ciliate columnar in the primary, the secondary, and the tertiary to the ciliated simple columnar epithelium with some goblet cells in our larger bronchioles to mostly ciliated simple cuboid epithelium with no goblet cells in the smaller bronchioles to mostly non-ciliated simple cuboid epithelium in the terminal. Now, am I going to ask you to know all that? No, but essentially, the further in you go, the less you're going to find cilia and the less mucus producing cells you'll have. And that's because hopefully by that point, you've already caught all the dust and you've moved that dust outward. So you don't need to have the ciliated cells. You don't need to have the mucus producing cells as much. Okay. Now, also plates of cartilage are gradually replaced by incomplete rings of cartilage in the primary bronchi before they completely disappear in the distal bronchioles. And as that amount of cartilage decreases, the amount of smooth muscle increases, which therefore allows for easier control of the airway size through contraction or through relaxation. We talked previously about vasodilation, vasoconstriction in our blood vessels. Well, we can also perform what's called bronchodilation or bronchoconstriction, and that's going to be in the airways. And it's essentially the same thing. Bronchodilation is where the airways open up, whereas bronchoconstriction is what happens when the airways close or pinch more shutward. Unfortunately, that actually can happen completely pinching shut, which is what happens when somebody has an asthma attack. Okay. Now, pretty cool to see over here on the right. Actually you can trace it all the way back up to the epiglottis and the structures of the larynx, and then you can see the trachea real nice, and then the different parts of the bronchial tree, at least the bigger parts anyway. Here in this image is a pretty cool illustration showing you not only the same things, but also you got the lungs on the outside. It's really kind of tough, in my opinion, to kind of tell what branches are being labeled. So I, typically don't worry about the image. I actually do really like this box though, and that kind of just helps you keep your head straight on the branching. It goes from the trachea and then all the way out to the terminal bronchioles. Notice here though that they have main, lobar, and segmental, whereas like I had you write them out as primary, secondary, tertiary. I guess they're kind of trying to go away from this order and going with main, lobar. Make sure you know them both ways. Now, looking at this picture here on the next page, which you guys don't have, we can see a nice anterior view showing you up into the neck where we got the cricoid cartilage labeled. We can see the very visible trachea. We can see where it divides. We can start to actually see some of those different branches of bronchial tree. We can see actually the esophagus, which we'll get into in our next lecture. We can see the lungs are labeled. Keep in mind though, the basically front part of the lungs has been removed, so we can see these interior structures, because you wouldn't be able to see them if the lungs were there. We'll get into the lungs a little bit more here in just a minute. But first we have to talk about the tiniest, but also the most important structures in our lungs. And that's because they are the primary structures for gas exchange, and those are the alveoli. All right, alveoli, once again, are the primary structure of gas exchange in the respiratory tract, where they go through what's called pulmonary external respiration. In other words, this is where we're exchanging carbon dioxide and oxygen with our blood. O2 is entering the pulmonary capillaries, entering the blood. CO2 or carbon dioxide is leaving it. Okay. Associated with alveoli are alveolar ducts and alveolar sacs, or as they're also described, saccules. And the ducts are the air passages that lead from the bronchioles into the alveolar sacs. Alveolar sacs or alveolar saccules are just clumps of alveoli with a common opening. Okay, we can see those here in our top left image. Okay, here's our terminal bronchiole. This is the tips of our tree. Okay, the last structures of the respiratory or the bronchial tree, about 0.5 millimeter in diameter. And then from there, branching off, and these are all going to be microscopic, are the respiratory bronchioles. And then coming off of those are the alveolar ducts. Now, I always tell students to kind of think of alveoli like grapes. Okay. Each of these little ball-like structures is what we call an alveolus, which is just the singular form of the word alveoli. Okay. Now, like grapes, they don't come in solitary situations. They come in clusters. A cluster of alveoli is an alveolar sac. Okay. We can see one of those is labeled here, but this would be another alveolar sac. This would be another alveolar sac. Here would be another one. Okay. Each of the little ball-like structures is an alveolus, and we can see a couple of them up here, but we can also see them all over the place down here. Okay. Now, each alveolus is only one cell thick, which is fantastic, making them very thin-walled. Also very thin-walled are the pulmonary capillaries, which are directly next to the alveolar cells, and therefore, the way that oxygen enters the blood, it has to pass through those different walls from the alveoli into the blood, and CO2 is going in the opposite direction, and it does so with very little resistance. Okay, what we call respiratory membrane is this junction between the wall of an alveolus and the wall of a capillary. Okay, this is the barrier for gas exchange. Okay, we want this barrier to be as minimal as possible. And in a good, healthy lung, it is absolutely as minuscule as possible. I want to say it's like 0.0005 millimeters, if I'm remembering right off the top of my head. That's, I don't even know if paper is that thick. I mean, it is extremely, extremely, extremely thin wall. Okay. Now, there are 4 layers that make up that respiratory membrane, and they are labeled over here where we've kind of zoomed in at that junction between a pulmonary capillary and the alveolar wall. Those 4 layers include what we call type 1 cells, or type 1 alveolar cells, as they're labeled as, which are going to form the wall of the alveolus. They are simple squamous. Remember, simple squamous tells you that there's only 1 layer of them, and squamous tells you that they are nice and flat plate-like. We can see that flat plate-like structure very nicely here in our illustration. So that cell is very thin. So is its basement membrane surrounding it, and we have essentially the same situation with the capillaries, which we've talked about capillary walls before back in our last unit. We learned that capillaries are made up of an endothelium, which is simple squamous, and a basement membrane surrounding it. Okay, its capillary basement membrane shown here in red, whereas the epithelial basement membrane is shown here in purple, associated with the alveolus. Okay. So those are the 4 layers, which once again are the obstacle for oxygen to enter the blood and CO2 to leave the blood to then be exhaled out. But it is a very minuscule obstacle, especially if we're talking a normal healthy lung, because those 4 layers are very, very small. Okay. Now, aside from their small respiratory membrane and the small walls, which allows for gas exchange to occur very easily, the fact that we've got millions of alveoli in each lung increases surface area, which therefore increases our ability to perform gas exchange. Okay, so that's fantastic. A normal healthy lung really, really is good at allowing oxygen to enter the blood and CO2 to leave the blood. Okay. Now, another name for those type 1 alveolar cells are pneumocyte type 1 cells. That's kind of a new term, I guess. I usually just call them type 1 cells, but make sure you know them both ways. Okay. They aren't the only cells that are part of alveoli. You also have type 2 alveolar cells, or which also go by septal cells or pneumocyte type 2 cells. They produce a fluid called surfactant. Okay, and surfactant is going to be found on the inside of each alveolus, where it's going to help reduce the surface tension inside of there. Surface tension is the force of attraction between water molecules. It also helps prevent the alveoli from collapsing and sticking together as we breathe in and out. And most importantly, it allows oxygen to diffuse more easily. Okay. So that surfactant is very, very important, and it's produced by the type 2 cells. Okay. You're also going to find what we call alveolar macrophages, or dust cells, which are phagocytes, which means that they are like Pac-Man. They are able to digest stuff, things like fine dust particles and debris that maybe didn't get trapped in the upper airways. Okay. You'll also find fibroblasts, which are connective tissue cells that produce reticular and elastic fibers. We don't see those fibroblasts later labeled, but we do see the reticular fibers and the elastic fibers that they produce labeled. Not that that's really important. Okay. Got some pretty cool pictures here showing you a lung lobule where we can see a terminal bronchial, respiratory, and then we can see the ducts. All these little ball-like structures would be the alveoli. Speaking of, we've kind of zoomed in even farther, showing you the alveoli and their kind of circular structure with the capillaries surrounding, and we can see the type 1 cells, type 2 cells labeled. But this image here and this image here are the two that you need to know. So here's what you need to highlight in our first image. Highlight the terminal bronchial in figure A. Highlight the respiratory bronchial. Highlight alveoli, alveolar ducts, alveolar sac, and then alveoli again on the kind of bottom left. Now keep in mind, this image is not perfect. It does kind of mislead. You see very nicely surrounding these alveoli are the pulmonary capillaries, whereas over here, these 3 sacs, you don't see any pulmonary capillaries. That's not going to be at all what's the situation in our body. Every single alveolus is going to have a very dense network of pulmonary capillaries, just like you see here. I guess they just didn't include them in these to keep the image a little bit more simple. So it's not a perfect image, but it is the best we got, nonetheless. As far as this image goes, I would say pretty much just everything that's capitalized for you is what you need to know. So the type 2 cell, the respiratory membrane, the type 1 cell, alveolar macrophage, and then these 4 things that are part of the respiratory membrane that are zoomed in on the far right. Now, it's important to understand that your lungs are not at all like an empty sac, not at all like an empty balloon. They're more like a sponge. Let's talk about our lungs. Each lung is a cone-shaped organ and therefore has a kind of triangular cone shape to them. That means they've got a broad concave base, rests on the diaphragm, and then a blunt peak called the apex that projects just actually above your clavicles. Okay, so they're similar to your heart that we previously talked about, and that it's kind of a triangular shape, except now the triangle's a normal triangle where the widest part is on the bottom and the pointy part is on top. Okay, whereas with our heart, we know it was the inverse. Okay, so we can see the base, the apex very nicely. Here we've got some real lungs on the right side in our 4 views there. Okay, Once again, it is not a hollow balloon-like structure, but instead is a spongy mass of tissue. It does contain millions of balloons, and that's what we just talked about, the alveoli, which are served by our pulmonary blood vessels. Okay. Our lungs lie against our ribs both anteriorly and posteriorly, and that's because our ribs curve from the back side to the front side. The surface of the lung lying against the ribs is called the costal surface, and it matches around the curvature of our ribs. And you can really get a good feel for that here in our two lateral views, where we can kind of see these little indentations or impressions, as they're labeled, from the actual cadaver lungs, which is kind of cool. We always know, once again, if you don't remember, the word costal refers to ribs. Okay. Now, the mediastinal or medial surface of each lung contains a hilum, which we've seen that word previously, the location where the primary bronchi, the pulmonary blood vessels, lymphatic vessels, and nerves enter and exit each lung. So in other words, this is the indented part of your two lungs, just like we saw, for example, your spleen and your lymph nodes have an indented hilum. Okay. Looking here, we'll be able to see them best here in the two medial views, and they are bracketed off here in the right lung view and then the left lung view. Okay. They're held together by the pleura, which we'll talk about here in a second, and connective tissue called the root of the lung, which is why you see in parentheses, root is labeled. Okay. The left lung, I already mentioned this, contains what we call the cardiac notch, a concave portion where the heart lies. And due to this, the left lung is about 10% smaller than the right lung. We get a little bit of a view of it here. This is a lateral view, so you're looking from the side, so you don't get a great view of it. You get a pretty good view here. Really, the best way to appreciate it is back here on this picture, where you can look straight ahead or from straight ahead, and you can see that cardiac notch very nicely. Each lung is divided into into lobes, and then subdivided into functional units called bronchopulmonary segments. And each of those is served by a tertiary segmental bronchi. Okay. We then can take those bronchopulmonary segments and divide those into lobules, which are served by terminal bronchioles. And I've already talked about this, but your right lung has three lobes, a superior, a middle, and an inferior lobe, whereas your left lung, since it's a little bit smaller, only has two, a superior and an inferior. Those are separated by what we call fissures. Okay, so there's two fissures for your right lung, a horizontal fissure and then an oblique fissure. The horizontal fissure runs in the horizontal manner, so sideways, whereas the oblique is kind of going at an angle, not quite straight up and down, not quite side to side, but somewhere in between. Whereas your left lung, since there's only two lobes, there's only one fissure, and that's your oblique fissure. Okay. Now, surrounding each lung, and I don't have any pictures to show them, but that's okay, is a structure known as the pleura. But we've already talked about this before, and it's pretty much just like what we learned about surrounding our heart, which we had the pericardium. We've got a strong connective tissue, which is a double membrane, includes the pulmonary/visceral pleura and the parietal pleura. Okay. The pulmonary or visceral pleura is the deeper layer that covers each lung, and then surrounding it is the superficial parietal pleura that actually lines the walls of our thoracic cavity. I first introduced this, just like I did with the pericardium, in our very first lecture of the semester, and probably have forgotten about that, but I wanted to mention it nonetheless. Now, there is a very small, and I describe it here as a potential space between those two membranes, what we call the pleural cavity. It's a potential space, and that's because these two membranes actually like to stick to one another. It's almost like they're glued to one another, and that's because there's a vacuum inside, not like the vacuum that you use to clean your carpet, but a pressure that attracts those two membranes together. There is a fluid in there that helps maintain that vacuum. We call this pleural fluid. It also helps reduce the friction between those two membranes, so they aren't, rubbing and wearing holes in one another and causing bad situations. That's because if you get air or even blood in that space, it's going to impact your ability to breathe. The two membranes are very essential for breathing. For those of you who are in physiology, we talked about that the other day, and we'll talk a little bit more about that probably this afternoon. If you get air in that space, it's called a pneumothorax. If you get blood in that space, it's called a hemothorax. If you've ever heard of a collapsed lung, it's where that connection, that attraction between those two membranes is lost. That vacuum has been eliminated, and it's probably because there's a hole in the parietal pleura, and thus the vacuum is not maintained. As far as the different images, I actually do want you to know figure BC and the two at the bottom, D and E. I would say pretty much everything in them would be fair game. You also are going to want to make sure that you can identify which lung is visible. You know, maybe I would just put this picture on the exam and say, which lung is this? You'd have to know, since there's 3 lobes, that this is the right lung, that this has only got 2 lobes, that this is the left lung. Okay. Should we identify the fissures, the different lobes, the apex, the base, the hilum, and so on and so forth. Okay. So make sure you can identify them both in the lateral and the medial views. I included a picture from your textbook, not that that's really something I'm going to look at too much, but this is a transverse section, so they've cut the basically top half of the body off, or not quite top half, but you can see down into the right lung, you can see a little bit of the left lung. Really demonstrates, and this is the big benefit of showing you this, your lungs are not hollow at all. And they're sponges. They are spongy in texture, not actual sponges, but they are made up of those millions and millions of alveoli. We do see the aorta, a couple different points in there. That's kind of cool. There's the ascending, there's the thoracic, you can see the pulmonary arteries, which we've talked about before, so I won't spend any more time on that. But to kind of reiterate what we just previously learned about, we can kind of now integrate the respiratory system with the cardiovascular system with regard to the flow of blood in and out of the lungs. As we've previously learned, deoxygenated blood, which is also described as blood that's high in CO2, comes into the lungs thanks to the right side of the heart that pumps the blood out into the pulmonary trunk, which then divides the pulmonary arteries. And then from there, the pulmonary arteries branch to form the pulmonary capillaries, and that's where gas exchange occurs. CO2 exits the blood, O2 enters it. And then now the blood comes back via the pulmonary veins, which is why you see those colored red. They're carrying oxygen-rich blood. And then we then pump that blood out through the left ventricle into the aorta to be distributed throughout the body. Just like our heart had its own network of blood vessels, so does your lungs, your bronchi, and your trachea. And those small systemic arteries and veins are known as bronchial arteries and bronchial veins. And as far as basically anything on this page, we've already essentially talked about it all, so we really don't need to worry too much about it. Any questions?